Dear students, after studying this module, you shall be able to identify the symptoms of traumatic brain injury, learn various methods of diagnosis and treatment of TBI, learn the causes of TBI, learn about preventive factors of TBI. An injury that results in the trauma to the scalp, skull or brain can be classified as head injury. The term traumatic brain injury and head injury are often used interchangeably in medical literature. Traumatic brain injury, also known as TBI or intracranial injury, is generally the result of a sudden, violent blow or jolt to the head. The brain is launched into a collision course with the inside of the skull, resulting in possible bruising of the brain, tearing of nerve fibers and bleeding. TBI may also be caused by objects such as bullets or a smashed piece of skull penetrating brain tissue. Causes of TBI may include falls, vehicle accidents and violence. TBI severity varies enormously and depends on which part of the brain is affected, whether it occurred in a specific location or over a widespread area, as well as the extent of the damage. In mild cases, the patient may experience only temporary confusion and headache. Serious TBI can result in a period of unconsciousness, amnesia, disability, coma, and even death. A head injury usually refers to a traumatic head injury but is a broader category. Head injury may also involve damage to other structures such as the scalp or the skull. Symptoms of traumatic brain injury. A symptom is something patient feels and reports, while a sign is something that other people such as the doctor detects. For example, pain may be a symptom while a rash may be a sign. TBI signs and symptoms may sometimes be subtle and might not appear for days or weeks after the injury. Some patients may look well even though they may feel or behave differently. Our brain controls our movements, thoughts, sensations and behaviors. A TBI can have several different physical and psychological effects. Initial physical effects are bruising and swelling. While injured brain tissue swells up, pressure is increased. The injured brain tissue presses against the skull, causing additional damage. The most common sign and symptoms of TBI include the following: confusion, fatigue and lethargy, getting lost easily, persistent headaches, persistent pain in the neck, slowness in thinking, speaking, reading or acting, moodiness, suddenly feeling sad or angry for no apparent reason, sleep pattern changes. This may include either sleeping much more or much less than usual or having trouble sleeping, lightheadedness, dizziness, becoming more easily distracted, increased photosensitivity, increased sensitivity to sounds, loss of sense of smell or taste, nausea, tinnitus, that is ringing in the ears. The same signs and symptoms as those listed above are possible in children also. However, children typically are less likely to let others know how they feel. If a child has received a blow or jolt to the head, any of these signs or symptoms may be present. Changes in the sleeping pattern, irritability. For example, the child does not stop crying and is hard to console, listlessness, loss of balance, will not eat, there is loss of interest in their favorite activities or toys, tiredness, unsteady walking. The TBI may be mild or severe. The symptoms of mild TBI are a short period of unconsciousness, blurred vision, tinnitus, or a bad taste in the mouth, cannot remember events immediately before and after the injury took place, confusion, dizziness or loss of balance, headache, memory problems, moodiness and problems focusing mentally. Moderate to severe traumatic brain injury signs and symptoms may include agitation, confrontational, continuous headache, convulsion or seizures, coordination problems, one or both pupil of the eyes, is or are dilated, patient does not wake up from sleep, persistent nausea or vomiting, profound confusion, slurred speech, and weakness and numbness in hands, feet, arms, or leg. Types of TBI. There are several types of TBI, such as concussion. This form of minor head injury refers to an immediate and transient loss of consciousness that is associated with a short period of amnesia. Many patients do not lose consciousness after a minor head injury, but instead are dazed or confused or feel stunned or starstruck. The mechanisms of a typical concussion involve sudden deceleration of the head when hitting a blunt object. This creates an anterior-posterior movement of the brain within the skull due to inertia and rotation of the cerebral hemispheres on the relatively fixed upper brainstem. Loss of consciousness in concussion is believed to result from a transient electrophysiological dysfunction of the reticular activating system. Contusion, brain hemorrhage, and axonal shearing lesions. A surface bruise of the brain or contusion consists of varying degrees of petechial hemorrhage, oedema, and tissue destruction. Contusions and deeper hemorrhages result from mechanical forces that displace and compress the hemispheres forcefully and by deceleration of the brain against the inner skull, either under a point of impact or as the brain swings back in the antipolar area. The clinical signs of contusion are determined by the location and the size of the lesion. Often there are no focal neurologic abnormalities, but these injured regions are later the sites of gliotic scars that may produce seizures. Skull fractures. A blow to the skull that exceeds the elastic tolerance of the bone causes a fracture. Intracranial lesions accompany roughly 2/3 of the skull fractures, and the presence of a fracture increases many-fold the chances of an underlying subdural or epidural hematoma. Consequently, fractures are primarily markers of the site and severity of injury. They also provide potential pathways for entry of bacteria to the CSF with the risk of meningitis and for leakage of CSF outwards through the dura. Severe orthostatic headache results from lowered pressure in the spinal fluid compartment. Sellar fractures, even those associated with serious neuroendocrine dysfunction, may be radiologically occult or evident only by an air fluid level in the sphenoid sinus. Fractures of the dorsum sella cause 6th or 7th nerve palsies or optic nerve damage. Petronos bone fractures, especially those oriented along the long axis of the bone, may be associated with facial palsy, disruption of ear ossicles, and CSF otorrhea. Cranial nerve injuries. The cranial nerves most often injured with head trauma are the olfactory, optic, oculomotor, and trochlear, the first and the secondary branches of the trigeminal nerve, and the facial and the auditory nerves. Seizures. Convulsions are surprisingly uncommon immediately after a head injury, but a brief period of tonic extensor posturing or a few chronic movements of the limbs just after the moment of impact can occur. However, the cortical scars that evolve from contusions are highly epileptogenic and may later manifest as seizures even after many months or years. The severity of injury roughly determines the risk of future seizures. Subdural and epidural hematomas. Hemorrhages beneath the dura or between the dura and the skull have characteristic clinical and radiological features. They are associated with underlying contusions and other injuries, often making it difficult to determine the relative contribution of each component to the clinical state. The mass effect and raised ICP caused by these hematomas can be life-threatening, making it imperative to identify them rapidly by the CT or MRI scan and to remove them when appropriate. Direct cranial trauma may be minor and is not required for acute subdural hemorrhage to occur, especially in the elderly and those taking anticoagulant medications. Acceleration forces alone, as from whiplash, are sometimes sufficient to produce subdural hemorrhages. A subacutely evolving syndrome due to subdural hematoma occurs days or weeks after injury with drowsiness, headache, confusion or mild hemiparesis, usually in alcoholics and in the elderly and often after only minor trauma. On imaging studies, subdural hematomas appear as chrestenic collections over the convexity of one or both hemispheres, most commonly in the frontotemporal region and less often in the interior middle fossa or over the occipital poles. Epidural hematoma. These evolve more rapidly than subdural hematomas and are correspondingly more treacherous. They are associated with underlying cortical damage less often than are subdural hematomas. Most patients are unconscious when the first seen. A lucid interval of several minutes to hours before coma supervenes is most characteristic of epidural hemorrhage, but it is still uncommon and epidural hemorrhage is not the only cause of this temporal sequence. Rapid surgical evacuation and ligation or cautery of the damaged vessels is indicated, usually the middle meningeal artery that has been lacerated by an overlying skull fracture. Chronic subdural hematoma. A history of trauma may or may not be elicited in relation to chronic subdural hematoma. The injury may have been trivial and forgotten, particularly in the elderly and those with clotting disorders. Headache is common but not invariable. Additional features may include slow thinking, vague change in personality, seizure, or a mild hemiparesis. The headache fluctuates in severity, sometimes with change in head position. Bilateral chronic subdural hematomas produce perplexing clinical syndromes, and the initial clinical impression may be of a stroke, brain tumor, drug intoxication, depression, or dementing illness. Drowsiness, inattentiveness, and incoherence of thought are more generally prominent than focal signs such as hemiparesis. Minor and major TBI. The patient who has briefly lost consciousness or been stunned after a minor head injury usually becomes fully alert and attentive within minutes but may complain of headache, dizziness, faintness, nausea, a single episode of emesis, difficulty with concentration, a brief amnestic period, or slight blurring of vision. This typical concussion syndrome has a good prognosis with little risk of subsequent deterioration. Children are particularly prone to drowsiness, vomiting, and irritability, symptoms that are sometimes delayed for several hours after apparently minor injuries. Vasovagal syncope that follows injury may cause undue concern. Generalized or frontal headache is common in the following days. It may be migrainaceous in nature or aching and bilateral. Persistent severe headache and repeated vomiting in the context of normal alertness and no focal neurologic signs is usually benign, but CT should be obtained and a longer period of observation is appropriate. The decision to perform imaging tests also depends on clinical signs that indicate the impact was severe. For example, prolonged concussion, periorbital or mastoid hematoma, repeated vomiting, palpable skull fracture, on the seriousness of the other bodily injuries and on the degree of surveillance that can be anticipated after discharge. 2 studies have indicated that older age, 2 or more episodes of vomiting, more than 30 minutes of retrograde or persistent anterograde amnesia, seizure, and concurrent drug or alcohol intoxication are sensitive but not specific indicators of intracranial hemorrhage. It is appropriate to be more liberal in obtaining CT scans in children since a small number, even without loss of consciousness, will have intracranial lesions. Causes of TBI. TBI is caused by a severe jolt or blow to the head or a head injury that penetrates and disrupts normal brain functions. Our brains are like a mass of gelatin which is protected from jolts and bumps by the cerebrospinal fluid around. A violent blow or jolt to the head can push the brain against the inner wall of the skull, which can lead to the tearing of fibers and bleeding in and around the brain. Not only can a blow cause injury to the brain, sudden and rapid acceleration or significant deceleration may cause TBI as well. According to the Center of Disease Control and Prevention, in the USA, the leading cause of TBI are falls, 28%, the most commonly affecting children aged up to 4 years and adults over 75 years. Motor vehicle accidents, 20%, highest among people aged 15 to 19 years. Struck by or against events, 19%, including colliding with a moving or a stationary object. Assaults, 11%. TBIs caused by firearm use are the leading cause of deaths related to TBI. 90% of the patients with a firearm related TBI die. Non-motorized pedal cycle, bicycles, tricycles, etc. 3%. Transport, 2%. Suicide, 1%. Child abuse. Traumatic brain injury is the third most common injury to result from child abuse in America. Other causes of TBI include domestic violence and work-related and industrial accidents. Diagnosis of TBI, the Glassgow scale. TBIs require rapid diagnosis and treatment because they are frequently medical emergencies which can easily and quickly lead to complications. Several Glassgow scales have been devised to ascertain the severity of TBI. Glassgow Coma Scale. Doctors often use the Glassgow Coma Scale, GCS, before deciding whether to use a CT scan. The GCS is a way for doctors and nurses to assess the severity of brain damage following a head injury. It scores patients according to verbal responses, motor responses, and how easily they can open their eyes. Eyes, Glassgow Coma Scale. Score of 1, does not open eye. Score of 2, open eyes in response to painful stimuli when given pain. Score of 3, open eyes in response to voice. Score of 4, open eyes spontaneously. Verbal, Glassgow Coma Scale. Score of 1, makes no sound. Score of 2, incomprehensible sounds such as mumbles. Score of 3, utters inappropriate words. Score of 4, confused, disoriented, and score of 5, oriented, chats normally. Motor physical reflexes. Score of 1, makes no movement. Score of 2, extension to pain stimuli, straighten limbs when given pain. Score of 3, abnormal flexion to pain stimuli, moves in a strange way when given pain. Score of 4, flexion or withdrawal to painful stimuli, moves away when given pain. And score of 5, localizes painful stimuli, can pinpoint where pain is. Score of 6, obeys command. Brain injury will be classified in Glassgow Coma Scale as comma is equal to a score of 8 or less, moderate a score of 9 to 12, and minor a score of 1. Comma score is equal to E plus M plus V. Patients scoring 3 or 4 have an 85% chance of dying or remaining vegetative, while score greater than 11 indicate only a 5 to 10% likelihood of death or vegetative state and 85% chance of moderate disability or good recovery. Intermediate scores correlate with proportional chances of recovery. Other methods of diagnosing TBI. These measures help determine whether there is any brain injury or damage and where it might have occurred. Examples include CT, computed tomography scan. It is also known as CAT, computer axial tomography scan. It is a medical imaging method that employs tomography. X-ray. X-rays are still used for head trauma, but experts say they are not so useful. If a head injury is mild, no imaging is usually needed, while a severe injury would merit the more accurate CT scan. MRI, magnetic resonance imaging scan. An MRI machine uses a magnetic field and radio waves to create detailed images of the body, which in this case would be the brain. Most MRI machines look like a long tube with a large magnet present in the circular area. When beginning the process of taking an MRI, the patient is laid down on the table. Thus, depending on where the MRI needs to be taken, the technician slides the coil to a specific area being imagined. The coil is the part of machine that receives the MR signal. MRI scans are good for examining the brainstem and deep brain structures. The doctor may inject a special dye which shows up on the scans and distinguishes healthy tissue from a damaged tissue. Angiography, a medical imaging technique used to visualize the inside or lumen of blood vessels and organs of the body. This may be used to detect blood vessel pathology when risk factors such as penetrating head trauma are involved. EEG, electroencephalography. The device measures the electrical activity within the brain. Electrodes are placed on the patient's scalp. They pick up electrical impulses that occur in the brain. These impulses are recorded on the EEG device. An EEG can tell whether the patient is having non-convulsive seizures. Intracranial pressure monitor. It is a device placed inside the head. It senses the pressure inside the skull and sends its measurements to a recording device. Brain injuries tend to result in swelling of brain tissue, which may cause additional damage to the brain. Treatment options for TBI. Most concussions or mild traumatic brain injury symptoms will go away without treatment. When treating traumatic brain injury, the focus of emergency care is to prevent any worsening of brain damage. The greatest risk of further brain damage is when the brain swells. If blood vessels were damaged when the injury occurred, there is a further risk of pooled blood or clots accumulating in this small space inside the skull where pressure is rising. The increased pressure in the brain can cause damage to the brain tissue just because of the pressure itself. The blood vessels to get squeezed, undermining their ability to supply the brain cells with oxygen and essential nutrients. Brain injuries can also result in a serious drop in blood pressure, further reducing blood supply to the brain. Medications. A diuretic is anything that encourages the formation of urine by the kidney. In other words, they increase urine output and reduce the amount of fluid in tissue. They are administered intravenously. Mannitol is the most commonly used diuretic for TBI patients. Some studies suggest that children may benefit from certain concentrations of saline solution. Anti-seizure medication. The risk of seizures during the first week following the traumatic injury is higher for patients with moderate to severe TBI. This medication may be administered to prevent further brain damage caused by seizures. Coma-inducing medications. Comatose patients require less oxygen. Doctors may sometimes deliberately induce coma if the blood vessels are unable to supply adequate amounts of food and oxygen to the brain. Rehabilitation. A number of TBI patients with significant injury need rehabilitation. This may involve relearning how to walk, talk, and carry out tasks which used to be done automatically. The aim is to help the patient gain as much physical independence as possible. Typically, therapy starts in the hospital and later continues in a residential treatment facility or in outpatient services. Depending on the patient's needs, they will be treated by either a physical therapist, in UK known as physiotherapist, or occupational therapist, or both. Besides medication, surgeries may be aimed at removing hematomas. A hematoma is an abnormal collection of blood which is either partially clotted or completely clotted. Often, when TBI patients arrive in hospital, they are taken straight to the operating theatre and have large deposits of clotted blood removed from between the skull and the brain, resulting in a reduction of pressure inside the skull, preventing further brain damage. Skull fractures. If any part of the skull is pressing into the brain, it will need to be surgically repaired. In most cases, skull fractures which are not pressing into the brain heal onto their own. Create an opening in the skull. This is done to relieve the pressure inside the skull. This procedure is only done if other interventions have not worked. Tips that can aid recovery. Avoid activities which could cause another jolt to the head. Do exactly what doctors and other healthcare professionals recommend. Do not take drugs your physician has not approved. Do not rush back to daily professional or school activities. Get plenty of rest. If you have memory problems, write things down. Only drive a car, ride a bicycle, motorbike, or use heavy equipment when the doctor says it is okay to do so. People's reflexes after a TBI may slower. Seek help in relearning skills that were lost. Possible complications of TBI. Seizures. These may occur during the first week after the injury occurred. Experts say that TBIs do not increase any individual's risk of developing epilepsy unless they have been major structural brain injuries. Infections. The meninges, the membrane around the brain, can be ruptured during a TBI, allowing bacteria to get in. If the infection spreads to the nervous system, there is a risk of serious complications. Nerve damage. If the base of the skull is affected, the nerves of the face can be affected, causing paralysis of facial muscles, problems with eye movement, double vision, and a loss of the sense of smell. Prevention of TBI. Car seat belts. Wear a seat belt every time you drive your car or ride as a passenger. Make sure children are buckled up using either a safety seat, booster seat, or a seat belt that is suitable for the child's size and age. When children outgrow their safety seats, usually when they weigh about 40 pounds, they should start using a booster seat. Children should continue using the booster seat until the lap or the shoulder belts fit properly, usually when they are about 4 feet 9 inches. Drinking and driving. Never drive when you are under the influence of alcohol. Helmets or specific protective headgears should always be worn when batting in baseballs, softballs or cricket, and running bases in baseball. Engage in contact sports such as karate, boxing, or American football, riding a horse, riding on a motorbike, snowmobile, scooter, or all-terrain vehicles, both riders and passengers, skiing, snowboarding, using a skateboard, and when roller skating or inline skating. Living areas for senior, elderly people in UK. Grab bars should be installed next to the bathtub and or toilet. Seniors should keep physically active to make sure lower body strength and balance is adequate. Make sure lighting in the house is bright enough. On bathtub and shower floors, use non-slip mats. Remove throw rugs and other objects which may cause tripping. Stairways should ideally have handrails on both sides. Living areas for children. Install window guards. Place safety gates at the bottom and the top of stairs if the children are young. Children play areas. The ground surface of a child's playground should be made of hardwood, mulch, sand or some specific shock absorbing material. Firearms. Firearms should be stored, unloaded and in a locked safe or cabinet. Bullets should not be stored in the same location. Summary. Any injury that results in the trauma to the scalp, skull or brain can be classified as head injury. The most common symptoms of TBI are confusion, fatigue, lethargy, getting lost. The various types of TBI include concussion, contusion, subdural and epidural hematomas, brain hemorrhage, etc. TBI can be diagnosed with the help of Glassgow Coma Scale and other imaging techniques. Prevention of TBI includes various safety methods during daily activities. Medical as well as surgical options are available to treat TBI. Prognosis in cases of TBI is largely dependent on the duration between injury and treatment. Thank you.